one, I'm sorry if I missed it, about the bone marrow transplants. What is the age cutoff, or is it a black and white age cutoff?
So it's not entirely black and white. Our program uses 75. Some programs have gone up into the 80s. There's sort of diminishing returns the older I think you get. But the other key piece of this is somebody really needs to be healthy enough and have a good performance status, meaning like they get up, they're able to do everything, spend their time outside of the chair.
Is there also a weight cutoff? Like my dad is a little bit overweight, not maybe a little bit, a lot. So he struggled with his weight for a while. So
Not really. I mean, I think if somebody has significant morbid obesity, it can make the transplant process more challenging, but I don't think we've ever excluded anyone on that by itself.
okay, I'm still pushing him, but I'm sure you guys have heard of the CRISPR technology, the gene editing. They take your bone marrow out, edit it, and put it back. I guess it got FDA approval last year for sickle cell anemia. And I heard something about it that it might be available for PV one day. What's your opinion on that? Or have you heard of it, or has it hit Mayo Clinic yet?
So I have heard of the CRISPR technology, and I'm familiar with some of the sickle cell data. I think with MPNs, it's very challenging because there's so many things going on. It's not just like if you take out the JAK2 mutation, awesome. And the other thing is that with the CRISPR, if you have a problem where if you replace 50% of that gene, they're going to be back to normal. So like sickle cell, hemophilia, if you fix 50% of the cells, this person has a much, much better quality of life. Unfortunately, it's very difficult to get like 100% replacement. So to actually be able to take the cells out and not have any cells that have any JAK2 left, and then we also aren't getting all the cells out of the person, even if we give them chemotherapy, there's always going to be some of those cells left.
Gotcha. Thank you.
But it is very important for research. So CRISPR is amazing and has really led to a lot of important discoveries. It's just not quite ready for human use in this setting.
My question deals with the fact that you were talking about the combination, the PLIB, or whatever you talk about, the trial drug. It helps with the spleen reduction and all that, but what does it do for the bone marrow scarring? Does it stop the bone marrow scarring?
So the combination therapy.
Yes, the combination therapy.
So yes. So I showed some data there that did show that in each case, the combinations of all of these drugs, whether it's selinexor, whether it's navtemadlin, pelabresib, when you look at the combination versus the single agent, there's greater reduction in fibrosis. So, just to be clear, I don't want to oversell that. So we look at the bone marrows frequently to look at mainly three things: the cellularity, how much cellularity there is, how much atypia, meaning how funny do the cells look? Are there funny-looking characteristics of the megakaryocytes? Those are the pathologic cells in the bone marrow that represent the disease and give rise to platelets, and then fibrosis or scarring, which can be graded. Whether we reduce someone's grade of fibrosis from 3 to 2 or 2 to 1 or something like that, it would suggest we're changing something. Whether that change can actually associate or correlate with clinically meaningful benefit is an outstanding question. I don't know if I'm making that clear. So I don't want to oversell things. I do get excited. I will admit, I get excited when VAFs go down and fibrosis goes down. But I'm careful not to oversell that to mean that we have changed your disease in such a way that you will live a longer, better life because of that. So one of the things that we do try to do in these clinical trials is when we get this kind of data read back, and it's all done centrally, so it's really try to standardize it. When we get these central reads back, we go back and we ask questions like, so the patients who had reduction in fibrosis, did they have deeper spleen responses? Did they have deeper symptom responses? Did they stay on the drug longer? Were their counts better? So for example, there's one assumption, which is unfortunately not always true, is that if you reduce the fibrosis, the scarring in the bone marrow, well, the blood count should get better because there's less scarring in the bone marrow. But unfortunately, that's often not true. It doesn't really change that. So, outside of actually transplant, where you fundamentally change the bone marrow, and 6 months later, you can really start to see regression of scarring and normalcy to the bone marrow, I'm not sure with any of these combinations I can confidently look you or anyone in the eye and say that reduction in that fibrosis is clearly an indicator of disease course modification. So we're modifying aspects of the disease, but whether it's sufficient to mean that that person is going to live a better life is still premature.
The other thing to keep in mind is it can take up to 1 to 2 years for fibrosis to go away after a bone marrow transplant, and that's when you're completely eradicating the abnormalities that drive that fibrosis.
A quick question on transplants. Is radiation no longer used in conditioning?
We use it sometimes, but not very frequently. There's certain protocols, for example, a haplo protocol that we use that is reduced intensity. I use a tiny bit of radiation, but we don't. We do use radiation for other indications, but not as much for myelofibrosis.
I am taking Prolia for osteoporosis, and I am PV, and I am on ruxolitinib. Is the Prolia going to dilute or change the effectiveness of the ruxolitinib? Is it going to change it at all?
Well, you're looking at me, but I'm going to let Marina, who did the PV talk, maybe answer that question. I don't think so, but Marina, I don't know if you have, I don't know if you can hear us, Marina.
Yes. Hi. So I wouldn't think that it would have an effect on ruxolitinib, or have an effect on the ruxolitinib's effect. I think these drugs work in different ways. And so I think you should be okay. But again, you also can judge by luckily we can see how effective Jakafi is usually in terms of are your blood counts better, are your symptoms better?
And just to be clear, Prolia is given to improve bone mineral density, which is not the same as fibrosis. So that's the density of the cortex of the bone. When we talk about fibrosis, we're talking about scarring inside the bone, in the medullary space of the bone. So this question comes up a lot because a lot of women do get, medicines like Prolia for osteoporosis. I'm not aware of any data, and I have lots of patients, as I'm sure Marina does, that get Prolia and do just as well on Jakafi. One is cortex of the bone, one is medullary part of the bone. I don't think there's a concern.
So I'm not sure how to ask this question. My MPN specialist says that I am low risk for my PV progressing to MF, which is wonderful. I'm trying to somehow work into that the VAF, is that what we call the allele burden? So mine is 64% of the JAK2 mutation, and I keep thinking that if more should be worse. So, but is it just that we don't know enough about VAF yet and how it contributes to the disease?
Well, I mean, I think, I don't know if it was Jyoti, someone showed the relationship between the VAF and the higher risk for thrombosis, bigger spleen, higher white count, and the potential for progression. So a higher VAF typically does associate with a greater disease burden. And there's a nuance between people who have greater than 50% or less than 50%. So if you have a VAF of 64%, then that tells me that you have at least some cells in your blood or bone marrow that have 2 mutations. So you have 1 mutation from on one of your chromosomes, but in the process of creating other stem cells, that one stem cell took in 2 mutated chromosomes and now is homozygous, has 2 mutations. So what happens, you have expansion of that clone and you see the VAF start going above 50%. So I think we do have a sense of what the VAF means and its calculation into things. I think how to translate that into personalized approaches to treating patients, I'm not sure we're at that point yet. We use the VAF, so a great example would be with interferon alpha 2A or 2B, or even with ruxolitinib, we do use the VAF, or at least I do, to track over time to see if that number is coming down. Are we reducing the clonal burden of disease? So the VAF does have an implication. The question that was asked earlier is, why doesn't my doc check the VAF? And the reality is because unless you're doing something, there is no point to check it. If you're doing something with the idea that like in studies, we do it all the time, but even commercially, if you're giving interferon or ruxolitinib, if you check it every 6 months, there are patients who have a clear decline in their VAF, and there is data, prospective data, that would correlate that reduction in that VAF of at least 50% with an improved event-free survival, less clotting, bleeding, transformation to myelofibrosis, and death. So there is this correlation, there is this link between it. I think the fundamental problem is that we don't yet have effective agents or combinations of agents that reduce that VAF by very significant or multiple log-fold reductions, like we do in CML, a cousin of PV, in which we follow the value of another molecular marker, but we can get that down to like 0.00032. We can get it to super low levels, and we know that those super low levels, and it is a simpler, one event-driven disease, that correlates with better outcomes. So there's complexity in these diseases that make it a little bit not so straightforward, and there's actually drugs that we don't actually have drugs that get it that low in most patients. So for most patients, the VAF is well known, is noted, but it won't necessarily change how we're treating you.
So can I just say one part of that back to you? What we do know is that the VAF, higher VAF correlates more to events, so clotting events or whatever. But so I'm looking at it, I'm not looking at it the wrong way, but it's not going to, it doesn't tell me, I don't know how it correlates to MF. You guys have other factors that get considered for that, and those are what are leading to what my diagnosis was. Okay, thank you. My head doesn't want to wrap around that.
And I think you'll notice, too, that each one of us answers these questions very carefully, okay? Just to be very clear. I think everyone recognizes that because, each question, we desperately try not to make a personal consultation because that's so wrong at so many levels. And I know you guys as an audience understand that. So you have to give us a little bit of slack when we answer these questions because we're very carefully in our heads calculating what we say so that it makes sense, but it's not overstating something that would be inappropriate.
The CALR antibody with regards to MF, wouldn't it also be appropriate to ET as well?
Excellent question. So, yeah, I was talking about MF, so that's what I highlighted. But yes, in the trial, we don't discriminate against CALR mutant ET patients. So there are cohorts of patients that are CALR mutant ET, CALR mutant MF, and we're actually evaluating these cohorts and looking to see, do these folks need the same dose of drug? Are we going to get the same outcomes? Because the diseases behave differently, but we don't know how the antibody will react or interact in those two populations. So we've separated them, but yes, CALR mutant ET is also included in the study. I should have been more clear about that.
Possible also that earlier intervention would be an advantage?
So, if I think that's always probably going to be true if the therapy is extraordinarily effective and safe. So if the therapy is very effective in wiping out mutant CALR cells and not introducing a lot of other very bad toxicity issues, then the natural course of clinical development typically is you start moving it earlier and earlier in the disease. Because if we have a very effective therapy, then it may not make sense to wait for someone to get very advanced or very sick. We don't know the answer to that yet, but that would be part of the calculation.
Can you comment on treatment options for MPNU triple negative patients with severe IgG deficiency?
It's a test.
Isn't it breakout time now? That's a challenging one. So NPN, I keep answering these questions because I never shut up, but I don't have to answer that. I would punt it to Marina. MPNU.
All right, that's totally fair.
So it's triple negative.
I think MPNU. And what was the last part? MPNU and something else?
Triple negative MPNU.
And low IgG.
With low IgG. You saw a few of
So
those
I'm gonna leave
yesterday.
low IgG. I think I'm gonna leave low IgG slightly out of this. But I think triple negative MPNU, I think would depend on what's going on with the patient, right? So what are the blood counts like? What are the symptoms like? And that, I think that would guide the approach of how to treat this patient best. So if this patient has a lot of systemic symptoms and splenomegaly, then a JAK inhibitor would be the right approach for this patient. If patient has some of the symptoms that JAK inhibitors would be helpful, then I think that would be the approach for this patient. And I think certainly, depending on everything else going on with the patient, and consultation for transplantation as something that should be an option, if appropriate, should also be done. But I think as is the general rule for patients with MPN, it depends on, and specifically, I guess more for myelofibrosis patients, depends on what's going on with the patients, not just the diagnosis itself.
And I also think that if you have both triple negative disease, so that means there's no clonal marker of disease, and they've latched on U, which means unclassifiable, that's like a great case for a second opinion. Because I think those are the cases where you really want another group to come in with another expert hematopathologist to take a look. Because if you see enough of these cases, you start to realize that they're not always as advertised. If you can't find a marker, and it's not clearly PV, ET, or MF, and it becomes U, then the question is it something totally else? You know, what are the other clinical variables that are present that would make us think it really is an MPN and not masquerading as something else? And I think that would be, you know, not knowing your situation, that would probably be my best recommendation, is get another opinion too, just to be sure.
We have time for one more question here. It's a big hand over there. All right, we're going to do two.
Oh, I'm sorry.
Linda seniority.
Yeah, that's true. Since most of the studies that I'm aware of anyway that have compared JAK2 to something else, it's always BAT, which includes a whole multiple amount of different therapies. Have any studies outside of, I think Silver did one, that compares interferon, especially over a long period of time, to the JAK2 inhibitors in MF?
Well, just to be clear, some of the studies, when they have BAT, best available therapy, actually do allow for interferon as an option that the investigator can pick. I'm not aware of any study that has, in MF, that has directly compared like Jakafi to interferon specifically. There are studies that are now in development to look at early phases of myelofibrosis with interferon to understand. And there are studies actually out of Europe combining interferon with Jakafi. And there are patients in this room that are also, you know, have sort of, again, that's not that's outside of the guidelines, but combining Jakafi plus interferon, trying to get the best of both worlds with the two drugs. But interferon is a very, very active drug, and I think most people would agree with that. JAK inhibitors are also very active drugs. I don't know that there's that much interest today in creating a study that compares the two. I think the interest is more in how can we go beyond these two very active drugs, maybe combinations, you know, of drugs with these drugs, but not necessarily going back and comparing the two. That's probably something that we would have done a decade ago.
Okay, thank you.
Thanks. Okay, one more.
So John talked a little bit about standard of care, basically getting to a point where you can prescribe maybe something to someone who comes in early and you diagnose them with a JAK2 mutation and say, okay, here's a prescription, no phlebotomies, nothing like that. I realize this is completely speculative, but I'm going to take whatever you say as gospel. For all of you guys, I mean, when do you envision some of these new medications being breaching that standard of care?
To be honest, I'm not sure I understand your question.
So in some cases, we're in phase 3 clinical trials, it sounds like, maybe this summer, and then, what comes after that, and what kind of timeline are we potentially looking at for some of these medications that can circumvent having to do phlebotomy?
Marina, that's for you. So question, I'm not sure if you're hearing the question. The question is, for the studies you outlined that are in phase 3 or moving to phase 3 for phlebotomy freedom, when would that be commercially available, potentially commercially available?
Yeah, I think potential is a big question here. So if it all depends, of course, on the results, right? Like let's say the results come out and they're amazing, promising, everything we were hoping for. Then it will depend how long the FDA will take, how long it will take the company to apply for the, for the new drug application, and then how long it will take the FDA to review all the data. So potentially it could be another year or two once the data comes out. But there are so many different steps that need to take place and so many ways things could go in different directions that it's really hard to predict at this point. But I think it could potentially be in the near future.
But I think as all of these new drugs hopefully come to market, right, we're going to have tools in the tool belt. You're not going to have necessarily like this specific drug is the first line therapy in every case every new diagnosis that you have, right?
Yeah, I mean, I think the more drugs we have, the more it's going to force us to, to create some sense of who are those drugs appropriate for, how do we sequence the drugs that we have, because it probably won't be one drug fits all. So there's an element of personalizing. I mean, that's why you have to, and it came up in this meeting today. I mean, it's not just what are the numbers. It's what are the goals of the patient, the expectations. What are the comorbidities that might make one drug unattractive if there's a toxicity, that could interact with another comorbid condition. So I think you really have to take all of those things into consideration. There may be a world in which, and I think it was alluded to at this meeting already, where mutations or molecular features may drive the decision making. It might be a molecularly defined therapeutic approach rather than a PV or an MF approach. So, that's where I think things will likely go is very targeted, personalized approaches. We're not quite there yet, but even with all of the drugs that are approved, you're probably still going to need someone who's really paying attention, who can weigh the risk and benefit of each one and make a selection for you that really meets that expectation of you as a patient.
All right, I think we're going to take a break and then we're going to go to the breakout rooms. But first I need to know